Good evening, and thank you everyone for joining us today. Uh, on behalf of Nari Division of Jackson Paul Pharmaceuticals, I, Amit Saxena, with Dr. Deepika Chabra, welcome you all to this webinar today organized by Haryana chapter of ISAR. We present to you Cystelia am formulated with ideal 40:1 ratio of myo-inositol and D-chiro-inositol to restore ovulations, reproductive health in women. We also have Lycorate AM tablets, natural lycopene fortified with N-acetylcysteine, enriched with CoQ10 and L-carnitine. For added advantage to win the race, Lycorate N contains two priority complex natural lycopenes as lycobeads from Israel and L-carnitine and L-tartaric acid in a ratio of 2:1 to give highest available L-carnitines as carnipios sourced from Switzerland. And warm and hearty welcome to all the esteemed faculties attendees. Please note this webinar is streaming live on Facebook and the link has already shared in the chat bot for you to circulate. To refer this webinar in futures, please visit our YouTube channel, Jackson Paul Medical Insights. Now I invite Dr. Jyoti Malik, Chairperson Haryana is chapter of ISAR and Director Roots IVF at JJ Institute and Medical Sciences, Bahadurgarh, to kindly initiate this session.
Yeah. Thank you so much, Jackson Paul. Thank you, Dr. Deepika. Thank you, Amitji. And today we are having this up-to-date episode 7 under the chairmanship of our national president, Dr. Amit Patki sir, and with his blessings, with his guidance, and with the guidance of Dr. Asha Bakshi ma'am, our national secretary. We are bringing this monthly journal club meeting with the help of our think tanks of ISAR. And for today, we have our expert, Dr. Sonu Balhara. Dr. Sonu Balhara is she was the past chairperson of the IFS chapter of Haryana, and she is presently the director ART Fertility Clinics Gurugram, and she has a lot of academic activities contributed to research papers, textbooks, and authored book on D&D Part 2 Obs and Gynae. And she is also associated with various charitable programs. So thank you so much, Dr. Sonu, for accepting our offer at the last moment and in this Diwali season. And actually, today being Dhanteras, I would also like to wish each one of you a very, very happy Dhanteras and a happy Diwali. So today we have two presenters, two very young, dynamic people from our Haryana ISAR. For the first article, we have Dr. Punita Dhingra, and for the second article, we have Dr. Niharika. Dr. Niharika is a senior consultant in IVF from the Accord Super Specialty Faridabad, and Dr. Punita is Director Sarthak Fertility and IVF Hisar, and she has a working experience in prestigious centers like Lady Harding, and also a consultant in KFSH. And she has many awards to her credit. She has a prestigious Purnima Nadkarni Award for the best presentation in International Conference of ISAR 2017. She won the also prize in the Life Conference in 2016 in Bangalore. And she has presented a paper on outcomes of frozen embryo cycles in International Conference of PCOS Society in 2017. So we would be starting with Dr. Punita first, and her article, the topic is over to Dr. Punita. You only will put your can share the name of the complete article there, and you can start the presentation. And then Dr. After your presentation, Dr. Sonu can add her comments, maybe give her guidance, and then we go on to the second presentation. So over to Dr. Punita for her presentation. Thank you.
Dr. Sonu Balhara ma'am, Dr. Jyoti Malik ma'am, Dr. Manju Dagar ma'am. Very happy Dhanteras to all of you. So it's a journal club presentation on elevated AMH levels as a prognostic factor in IVF cycles in women with PCOS. PCOS, we all know, is it's a syndrome which affects 5 to 18% of reproductive age women, and it is characterized by amenorrhea or oligomenorrhea, clinical or biochemical hyperandrogenism, and polycystic ovaries on ultrasound. Anovulatory infertility is one of the major cause of infertility due to PCOS. And when simple ovulation induction and timed intercourse and IUI cycles fail, they prove to be unsuccessful, then control ovarian stimulation with IVF or ICSI is the treatment option in PCOS patients. Many of the predictive markers have been evaluated and studied in the evaluating the pregnancy outcomes in PCOS women in ART cycles. Some of the important being women's age, BMI, AFC, AMH, and the FSH measured on the third day. And even a combination of these, so many algorithms have been set, where a combination of these predictive markers have been set as models to predict the outcomes in the ART cycles. Today, we will be discussing the role of AMH as a predictive marker in ART cycles. AMH, we all know, is a glycoprotein synthesized by the granulosa cell, and granulosa cells and small antral follicle involved in the and the granulosa cell differentiation and growth. AMH is a marker of ovarian reserve, and it has been evaluated in many studies as a predictive marker of pregnancy outcomes in ART cycle. However, there have been many studies which have been in pro and in contradictory findings. Some of the earliest being the studies like McLeese et al. Of the role of studying the role of AMH in assessments in the ART outcomes, published in 2016. In the present study, we will be. I just wanted to check whether the screen share is showing the whole presenting slide.
Yeah, ma'am, it's full screen.
It is. Okay. So the present study is a retrospective observational study, and it was designed to assess the relationship between the AMH levels and the IVF outcomes. In this, around 150 women with PCOS who underwent IVF treatment with autologous self-oocytes in a single institution between 1st January 2018 to December 2022 was studied over a span of 4 years. This study was published by Well Fernandez et al. In 2023 in the Biomedicines Journal, and they studied the elevated AMH level as a prognostic factor for outcomes, for fertilization outcomes in women with PCOS in ART cycles. The materials and methods. So electronic medical records were used for data extraction, and a study protocol which was designed was approved by the ethics committee of the institution. Coming to the inclusion criteria which were specified. The women diagnosed with PCOS were based on Rotterdam criteria 2003, presence of at least two of the three following characteristics. We know that Rotterdam criteria, at least two of the following characteristics, which is the clinical or biochemical signs of hyperandrogenism, oligo or anovulation, and polycystic ovaries on ultrasound. These were the criteria which were taken as an inclusion criteria. Out of the exclusion criteria, a presumptive diagnosis of PCOS without fulfilling the Rotterdam criteria were not included in the study. And subjects which had a clinical or biochemical hyperandrogenism due to causes other than PCOS were also excluded from the study. As per the protocols, the low AMH, the women were categorized into 3 groups based upon the baseline AMH serum levels. There was a low AMH, middle AMH, and the high AMH group. The low AMH group women with AMH levels below the 25th percentile, that is the AMH of less than 3.7 nanogram per ml, and who underwent ART cycles were included in the low AMH group, and the number of was 49. The middle AMH, the women with AMH levels between the 25th to 75th percentile, values ranging between 3.7 to 7.4 nanogram per ml, the number of women being 97. And high AMH women with AMH levels above the 75th percentile with AMH values greater than 7.4 nanogram per ml, and in this 54 women were included in the study. All of these underwent the GnRH antagonist protocol for the IVF stimulation, and as per the after the oocyte retrieval and view on day 3, one of the 2 embryos with the highest score were selected for one or 2 embryos with the highest morphological score were selected for transfer. Any of the remaining embryos were either cryopreserved or were allowed to continue development to the blastocyst stage for fresh embryo transfer or cryopreservation. The primary outcomes which were evaluated were the positive beta HCG test, clinical pregnancy rate, live birth rate, and the cumulative live birth rate. The statistical methods which were used was the data extraction was done by the SPSS method. A statistical significance level of 0.05 was used for all the evaluations. The categorical data were expressed in either percentages or number of cases, and comparisons were done using the chi-square test. Continuous data were evaluated by mean or plus minus standard deviation and were assessed for normal distribution and homogeneity of the variance. When the data did not fulfill the criteria of normal distribution, then the Kruskal-Wallis test was employed. Now evaluating the results. So these are the results which were evaluated for the reproductive characteristics, and the women were divided into low AMH group, middle AMH, and the high AMH groups. As we can see the results here, there were no statistical significant difference in any of the reproductive characteristics like age, BMI, weight, primary infertility factor, and the male infertility factor in the duration of infertility. But the significant findings were there was a significant difference between the FSH levels and the LH-FSH ratio. So women with PCOS and the lower MH levels tended to be older and they had a lower BMI, although this was not statistically significant. So as you can see here, the average age in the low MH group is 33.83 plus minus 3.91, and in high image was slightly lower average age, but there was no statistical significant difference. Similarly, the BMI was 66.15 in low MH groups, and in high MH groups it was 69.46. Statistically, no significant difference. There was women with higher AMH levels had higher LH levels and lower FSH levels. And LH to FSH ratio was greater than 1 in all the 3 groups. But there was statistical significant difference between the low and the high group and the middle and the high group. Going back to the previous slide, as you see, the FSH levels are highest in the low AMH groups. Here, it was 6.65 plus minus 1.44, and in the high image group, it was 5.58 plus minus 1.2. There was statistical significant difference between the comparisons. And LH to FSH ratio was high, more than 1 in all the 3 groups, and there was statistical significant difference as comparison to the low and the high group and the middle and the high. Coming to these slides, which is comparing the pregnancy outcomes, the primary parameters, and some of the IVF cycle parameters. So as you see, the clinical pregnancy parameters, the pregnancy outcomes, which includes the positive beta HCG, the clinical pregnancy rate, the live birth rate, and the cumulative live birth rate, which show towards the end of the table. All these 4 are statistically significantly high in the low AMH group, and these low AMH group than the high AMH group and the middle AMH group. The p-value of positive beta HCG being 0.002, the p-value of clinical pregnancy rate being 0.013, live birth rate by 0.005, and cumulative live birth rate, the p-value is 0.009. Besides, there was some difference in the fresh embryo transfer rate. In the high MH group, there were very low fresh transfers which were done. There were higher fresh embryo transfers done in the low MH group, and the freeze-all was more in the high MH group. And this was statistically significant difference in the fresh embryo transfer and the freeze-all among the 3 MH groups. And oocyte immaturity rate was also higher in the high MH group, which was 18.63, and statistical significant difference with p-value being 0.002 difference between the high and the low AMH groups. Sum up. So all pregnancy-related outcomes, that is the positive beta HCG, the clinical pregnancy, live birth rate, and cumulative birth rate, was significantly higher in women with a low MH group in comparison to women with middle or high MH groups. And a binomial a logistic regression analysis was then conducted to adjust for the confounder factors on live birth rate. These factors were the age, BMI, FSH, and AMH as independent variables. This was done to establish any correlation between the AMH and the live birth rate. So as per this result of this multivariate logistic regression analysis, no significant association was revealed between the AMH and the live birth rate and the cumulative birth rate, the p-value being less than 0.05 in both the cases. Similarly, the establishment of correlation was also studied with the ROC curves, and the predictive power of the baseline AMH for live birth and cumulative live birth was explored using ROC curves. The area under curve for live birth rate being 0.382 and area under the curve for cumulative live birth rate being 0.507, p-value of live birth rate being 0.119, p-value for cumulative live birth rate being 0.068, and both of so AMH was found to have a poor predictive value to be able to correlate with either live birth rate or cumulative live birth rates. Coming to the discussion, the present retrospective study, which we just studied in women with PCOS, explored the impact of serum AMH levels on outcomes, live birth rate, and cumulative birth rate, live birth rate. Women with PCOS and lower AMH levels achieved higher rates of live birth and cumulative live birth rate in the IVF cycles, and lower number of IVF cycles with the freeze-all strategy was done with the lower AMH levels. Low serum AMH women had significantly higher live birth rates, p-value being less than 0.05, and higher cumulative live birth rate, p-value being 0.09, as compared to the middle and the high AMH groups. So as compared to the lower AMH groups and the middle and the high AMH groups, the cumulative live birth rate was higher and statistically significant, with p-value being 0.09. And study did show that the women with high AMH had significantly lower rates of clinical pregnancy, live birth, and cumulative live birth when compared to women with middle or low AMH levels. Similarly, these findings were also have been as we just showing the cross references. They were evaluated in many studies, and some of the cross references are a study by Zai et al., which was published in Journal of Assisted Reproduction in 2012, in which they compared the AMH levels on day 3 of the IVF cycles, and women with high AMH levels had a significantly decreased implantation rate, and there was increased LS concentration, and a clinical pregnancy rate was also lower. Similarly, many studies have been done by Tal et al. A study published in the Reproduction and Biological Endocrinology in 2020, which compared high serum, also evaluated the similar AMH levels with pregnancy outcomes. It also showed that high serum AMH levels were associated with lower live birth rates in women with PCOS undergoing ART. Also, the ROC curve analysis for AMH as a predictor of live birth was done in these studies. This also showed a statistically low correlation of the AMH with the live birth, indicating an overall poor predictability of live birth as per the AMH levels. Recently, systematic meta analysis was published in Reproduction and Biological Endocrinology in 2023, a study which was published by Yuvan et al. And it evaluated many studies and to establish an association between serum AMH levels and IVF outcomes in PCOS women. And the major result of this systematic review analysis was that an inverse relationship between the pre-pregnancy serum AMH levels and the clinical pregnancy in PCOS outcomes was noted, and this was statistically significant with p-value of 0.008. And this holds a lot of evidence. Besides these things, also this current study, which we just studied in this journal club, it lays a groundwork to validate that AMH levels can be used as a prognostic factor for pregnancy after IVF in women with PCOS, as AMH has been found to be associated, AMH levels low of less than 3.7 has been found to be associated with better pregnancy outcomes. So still further studies are needed, but again, it can be considered as a groundwork. In many studies, like published by LV et al. In BMC in 2022, also evaluated the cutoff levels of the AMH to be able to assess whether there will be a good ovarian response or a bad ovarian response. And an AMH levels under 3.5 nanogram per ml were linked with good ovarian response in this study. Also, the study which we are discussing now also found an inverse relationship between the FSH levels and the AMH levels, and a positive trend between LH levels and AMH in women with PCOS, in accordance with the previous studies. Coming to the limitations of the study. So limitations again, as we are discussing, that still we need a lot of studies, and we need to know the limitations of the study so that we can work up on our further prospective studies. So in this study, the main limitations were that it was a retrospective study. A retrospective study which was limited to the previously available data, which we just discussed, over a period of 4 years. So any subtle modifications of a protocol and some confounding factors which can be modified as per the patients and as per the need of the study are usually cannot be done in a retrospective study. So this was the limitation to this study. Also, evaluations like androgen levels, some phenotypic variations in the women also can be lacking when you are looking for a retrospective study. Then another limitation was the small sample size of the study. There were only 150 women which were evaluated. Thirdly, the endometrium was not evaluated in this study, which again, we have to understand, although PCOS is a chronic anovulatory state and a chronic anovulation and is the main defect in with this PCOS patient, and this is the factor which leads to the limitations of their success rates and whether in natural cycles or IVF cycles. But patients who have had PCOS for a long time and there are other coexisting factors like endometritis and even the effect of high androgen levels on the endometrium and oxidative stress could be a cause of recurrent implantation failure in these patients. So there was a lack of endometrial evaluation as per the study. Also, this study was conducted at a public center where the IVF treatments were restricted under 40 years and were avoided in women who were morbidly obese. So the cluster of women which were studied were of a narrow age and a narrow BMI interval. This could be one of the factors, confounding factors, which could have affected the outcomes of the study, and the confounding factors as well, especially in the multivariate logistic analysis. And lastly, not all embryo transfers was blastocyst transfers. As we know that, as we just saw in the protocols, that a lot of day 3 fresh embryo transfers done and few were taken to the blastocyst stage and many were cryopreserved, and then later in some of them the freeze-all strategy and the frozen embryo transfers were done. Why we are talking about blastocyst transfer, because these days it is considered as the gold standard for ideal for practices for IVF practice and ART cycles for optimizing the embryo implantation. So this could be one of the limiting factors in this study. Also, PGT was not done. This could be a limiting factor in the studies when we're comparing with other studies specifically. So these were the few limitations of the study. Coming to the conclusions, the findings in this study uphold the evidence that in women with PCOS, high AMH levels do have a negative impact on clinical pregnancy, live birth rate, and cumulative live birth rate. And the study also confirms that the AMH level could be of clinical utility to predict the treatment outcomes. AMH could be useful for counseling women with PCOS on expected IVF outcomes. AMH and especially, these two, the predicting the treatment outcomes, counseling the women with PCOS has been studied. Even it has been mentioned in the systematic review analysis, which was published in 2023, which we just showed the cross-reference. So these have been established and these have to be considered as a treatment outcomes and counseling outcomes. And AMH, we know, has been studied for the ovarian reserve as a biomarker. It is established, but it can also as a biomarker of disease severity in PCOS and prognosis in PCOS. It has a significant role. AMH cutoff levels to predict the better outcomes can also be further evaluated, like cutoff levels as we just show. And in previously studies also, they have been evaluated, and this could be considered as a ground level, or pilot studies are needed to establish the AMH cutoff levels for better outcomes in pregnancy, in PCOS women, even in healthy women. But still again, large scale, high quality cohort studies are still needed to confirm these findings. A very thank you to all of you.
Thank you, Dr. Punita. So that was a very nice, comprehensive review of this paper. So as you have rightly said, the study has got so many limitations, like it's a retrospective study with a small sample size. But the biggest thing is that they have done a fresh embryo transfer, and it is a day 3 embryo transfer what they have done. They
Yes.
have not taken into account patients who were, like, if they were developing ovarian hyperstimulation, or what kind of trigger was given, whether it was a dual trigger or only an agonist trigger,
Yes,
and the
ma'am.
progesterone levels. So
Yes.
that is very important in PCO patients who have high AMH levels.
Yes,
So
ma'am.
we usually do a freeze all for these kind of patients, because as you rightly said, the endometrium is not very receptive for the embryo in these patients.
Yes, ma'am.
So it has got quite a few limitations this study has.
Yes, ma'am.
And in the conclusions, they have said that high AMH level patients, it would not be a very good counseling if we tell them that if you have a high AMH level, you will have a lower pregnancy rate. So
Yes.
it has got quite a few limitations.
Yes, ma'am.
But thank you for the great summary of the paper.
A very thank you to ma'am.
Yeah, we can go on to the next one, I think. I
Dr.
think Dr.
Niharika
Niharika,
Sharma,
yeah.
she's the IVF consultant at Faridabad Accord Offspring Sector 86.
Okay, ma'am. I'm currently working as IVF consultant at Accord Offspring IVF Center at Accord Hospital, Sector 86, Faridabad. Previously, I was associated with Dilkant Hospital and its Seeds of Innocence. A very warm welcome and thank you, ma'am, for giving me this opportunity. So, ma'am, let me start my today's article. I'm going to talk about the article which has given to me. The article is what should be the minimum number of mature oocyte which is needed to obtain at least one euploid blastocyst according to female age in IVF treatment cycles.
Dr. Niharika, you can put it on slide
Yes, ma'am.
show. Yeah.
So, ma'am, the objective of the study was to find the minimum number of M2 oocytes needed to obtain at least one euploid blastocyst according to the female age. Ma'am, as we all know, the female age is directly proportional to the embryo aneuploidy rates. And by as an average, if we see by at the age of 35, nearly 40% of the embryos are aneuploid. But as the female age increases, the aneuploidy embryo rates in embryo increases. So that by the woman reaches the age of 45, approximately 90% of the embryos are aneuploid. So the dictum is the older the patient, the lower the number of euploid blastocysts available for transfer. So the most frequently asked question which the patient asks and which linger on in our mind also, how many oocytes are required to obtain at least one euploid embryo according to the female age? And why this question is important? It is important for both the clinician as well as the patient. For the clinician, it is important as to enable to assess each patient possibilities and feasibility of their treatment cycle. And as well as for the patient also, it is very important as to help her to understand the success of ART and to cope emotionally with the treatment. Any past research? Yes, it has been done in the past in the Poseidon group, which was published as a novel prediction model in approximately 1,300 tofu ectoderm biopsies in 2019. They estimated the probability of blastocyst euploidy and the number of blastocysts required to obtain at least one euploid embryo for transfer on the basis of female age. They designed a computerized tool, which is known as ART calculator, to determine the number of M2 oocyte needed. So coming to material and methods, first the study design. It was a retrospective analysis of all the treatment cycle, IVF treatment cycle with PGT-A, over 5 years in IVI-RMA Center, which is located at Valencia, Spain, and it was 5 years was from January 2017 to March 2022. They included the study population of eligible patients between 18 to 50 years, and they did not take in any account any BMI and AMH values. IVF PGT-A cycle was included, in which at least one mature oocyte was obtained regardless of the oocyte and semen origin. PGT-A was performed on day 5 or day 6 embryo by trophoectoderm biopsy and analyzed by next generation genome sequencing. The inclusion criteria for PGT-A were recurrent implantation failure, recurrent pregnancy loss, male factor, advanced maternal age, previous chromosomopathy, with advanced maternal age being the most common. The exclusion criteria of PGT-A were any known abnormal karyotype in male or female, or any structural alternation in karyotype. The study population, they divided into 2 categories. First, the donor group, in which the IVF PGT-A cycle were conducted using donor oocyte, and there the donor age was between 18 and 34 years. Second group was the patient group, in which IVF PGT-A cycle were conducted with own oocyte, the age being more than 35 years. The age was taken as more than 35 years to avoid any bias related to PGT-A indication in younger patients. And only the first IVF PGT-A cycle was performed per patient was included. The routine IVF COS protocol was done. Gonadotropin dose was calculated according to age, BMI, and ovarian reserve testing. Recombinant FSH or either HPHMG or both were used. Trigger was used as GnRH agonist or recombinant SCG or both. Oocyte retrieval, denudation, and ICSI was performed as usual. Fresh oocytes were fertilized after 4 hours, and vitrified oocytes were fertilized after 2 hours of thawing. Fertilization check was done after 16 to 20 hours. Assisted hatching done on day 3 embryos. After media change on day 3, embryos were cultured until day 5 or day 6. Embryo grading they have done according to their Spanish grading system, which ranged from A to D, with A being the best, and only they had taken the embryos between A to C, and they discarded the grade D embryos. Blastocyst biopsy was done with approximately 5 trophoectoderm cells using the pulling method. Euploid embryos were warmed during the Kitazato method and transferred using modified natural cycle or hormone replacement treatment ET protocol. Now they had done a statistical analysis by descriptive analysis was performed. Continuous values were summarized according to mean, standard deviation, and confidence interval. A homogeneity analysis has been performed to identify variables. Categorical variables were shown using proportion and was compared using the X-square test. In the patient group, a multivariate binary logistic regression was performed. This model was created using 80% of the This model was created using the 80% of the patient group sample, which is known as the training set, and internally validated using the remaining 20% of the sample, which is known as the validation set. The results were a total of 2,660 IVF PGT-A treatment cycle were performed. Out of these, the 92.6% were treatment cycle from women with their own oocytes, that is the patient group, and the remaining 7.4% cycle were treatment cycle with donated oocyte, that is the donor group. This is the descriptive analysis of the treatment cycle. As far as the age is concerned, the mean age in the patient group was 40. And in the donors were 25. The BMI was comparable in both the patient and the donors group, being 23 in both the groups. The AMH in the patient group, obviously it was lower as the patient age was taken more than 35 years. It was 1.8 nanogram per ml. In the donors, it was very high. It was 5.1 nanogram per ml. In the patients group, nearly 94% of the oocytes were taken as fresh, and only 2% of the cycle were taken as a vitrified oocytes. While in the donors group, only the 56% was fresh oocyte, and remaining 38% of the cycle were taken as the vitrified oocytes. This is the treatment cycle outcome and their comparison. In the donors group, as the number was less, so they have compiled the data in one group, and the number was 198. and in donors group, nearly 4.5%, only the 4.5% cycles were there in which they have found no biopsy blastocyst, and in approximately 8.5%, they have not been able to found only at least one euploid blastocyst. That was the donors group. But in the patients group, nearly 22% of the cycle were there in which they were unable to find even a single blast that is available for blast biopsy. And subsequently, in the 55% of the cases in the patient group were such in which they couldn't obtain even a single euploid blastocyst, and which in both the cases, in the biopsy blastocyst as well as the euploid blastocyst group in the patients, the incidence were gradually increasing as the patient's age increased. So this is actually this table I have made, ma'am, because it was given in really graphical form that was really
Yes, it was.
to understand. Yes, ma'am. And the number of blastocysts as coming as points because it is a statistically analysis. So they had performed such. They have done some logistic regression analysis to find the correlation. So in this table is formed between the donors group, which is 18 to 34 years, and they had suggested that approximately 2.6 or maybe 3 oocytes, M2 oocytes are needed to obtain at least one biopsied blastocyst, whereas to obtain euploid blastocyst, nearly you need 4.3 or maybe 5 M2 oocytes. While in patients group, they have divided between 8-9 groups ranging from starting from 35 to 44 years, and subsequent gradually as the patient's age increases, the number of oocytes needed to biopsy blastocyst needed to get the biopsy blastocyst gradually increases, and at 35 you need 2.8 number of oocytes, while as the age increases and if the patient is of 44 years, nearly you will need approximately 5.7 oocytes. While if you want euploid blastocyst, at the age of 35, you need approximately 5 M2 oocyte. But at the age of 44, if you need a single euploid blastocyst, the number is range very high. It approximately 4 times as the number you need at the 35 years. So one inference we can take it from there that the number of M2 oocyte needed to get the biopsy blastocyst is not increasing that much. It is just a double, 2.8 to 5.7. But in comparison, if you need the euploid blastocyst, you need approximately 4 times of M2 oocyte to just get one euploid blastocyst.
You have made a very nice table, Dr. Niharika.
Thank you so much, ma'am. This is the original graph I have taken from the study. In the X, there are 2 variables. On the X, they have taken the number of oocytes ranging from 0 up to 54, I think. And on the Y-axis, this is the probability of getting the euploid blastocyst range, probability being 0 to 100%. And there are 9 area under curve. As the age of the patients is starting from the younger patient, which is at the left, and the oldest patient, which is I think 49, it is on the right. So to get at the same number of oocyte, the probability of getting the euploid blastocyst subsequently decreases as the age advances. So coming to the discussion, it was the largest database retrospective analysis which is showing the association between female age and aneuploidy rates in IVF PGTA treatment cycle. It included 2660 treatment cycle with accessible and well-documented PGTA information. And only the IVF PGTA treatment were included using NGS on trofactodome biopsy on day 5 or day 6. This study included treatment cycle with both own and donated oocytes, in contrast to many of the already published studies. The group of donors has been proposed as a reference group to counsel the patient that this is the chance you have got to get a good blastocyst, a good euploid blastocyst. You need as many as oocyte, and versus if you go for the donor oocyte program, that much oocyte will be needed just to produce one euploid blastocyst. So this can be useful in clinical practice to show that patient what their chances are in case they move into the oocyte donation programs. Data showed that the mean number of euploid blastocysts decreases as the maternal age increases, hereby present as oocyte age. Likewise, the minimum number of M2 oocyte needed to biopsy at least one blastocyst and to obtain at least one euploid blastocyst increases with oocyte age, keeping these number low in the donors group. All investigators and authors have clinically demonstrated the association between maternal age and impaired oocyte meiotic progression. With age, the oocyte loses the capacity for optimal spindle assembly, chromosome segregation, and its mitochondrial function aggravates, leading to suboptimal oocyte meiotic progression. One of the strategies that can be suggested to the patient is oocyte or embryo accumulation before an IVF PGTA treatment cycle as per her age to increase the cohort of the available blastocysts for trophectoderm biopsy, augmenting the possibility of obtaining the euploid embryo. What are the limitations of this study? As the model showed a 72% validation with a sample set, it should be optimized more. An internal validation with a training set, which is 80%, and the sample set, which is 20%, was done. But multi-center external validation is also needed to make it more predictable. It was a retrospective study which makes the confounding to control more difficult, but larger sample size and multivariate logistic analysis allowed some control of potential confounders. So the conclusion is the minimum number of M2 oocytes needed to have high chances of obtaining at least one euploid blastocyst increases with the increasing maternal age. This model estimates the probability of having at least one euploid blastocyst considering oocyte age and M2 oocyte with a 72% accuracy. Once this model has been validated prospectively and in multi-center studies, it may be useful for both the clinicians and the patient coming to an infertility clinic. This data proposes the best strategy for each patient to understand the likelihood of obtaining an euploid blastocyst, helping her to cope emotionally with IVF treatment. Thank you, ma'am.
So, Dr. Niharika, this was a very nice summary and am I audible?
Yes, ma'am.
Okay, so as you have concluded, this paper, it gives a really good counseling sheet for us so that in the elderly patients, we can counsel and give them at least an idea that how many oocytes are needed for them to have a euploid blastocyst. But still, if we counsel them, maybe it is a little bit depressive for them to straight away go on to donor cycle programs and even for the first cycle if they are going for IVF. So that is the limitation. And even they have not taken into account the lab conditions, I think. So only the number of oocytes, it does not depend. Lab plays a very important role in the number of blastocysts, what we get in them. So both the papers have been great. And I think today there are very few people, so the discussion would not be very, like it cannot be very interactive between. So, Dr. Deepika, should we conclude? I think everybody is in a festive mood. I think Deepika is also gone for her Dhanteras puja, I suppose. So, thank you, Dr. Niharika, and thank you, Dr. Punita.
Thank you.
Both are good papers, and you have summarized.
We can ask the attendees if they have any questions.
Yeah, I think if anybody has a question, you can please ask, or you can type in. You are welcome to. We can have one or two questions. You both want to ask each other anything? If
I think it was an excellent presentation by Dr. Niharika.
Dr. Punita, you will yes. In art, they have done a difference, ma'am, in the art calculator this Poseidon has done. They have divided the patient in three categories: the 70% success rate, 80%, and the 90% ART success. According to those success, they have calculated the minimum number of oocytes. But in this current study, they had taken no ART success has been taken into account. They just thought that it is 100% success. If you get a euploid, that means you will have a 100% ART success. They are not correlated the euploid blastocyst transfer with the ART success. So that is the, I think, main drawback, and is compared as it is a little different from ART calculator. So it's one step ahead the Poseidon has done. So just to elaborate, the patient, see, if you want 70%, you need such number of that many number of M2 site, 80% that many number. But they have not done anything like that. They just have produced that how many euploid blastocysts will be needed just. And they have not collaborated with the pregnancy success rate in this.
But still, with this paper, we can individualize the treatment protocols also for the patient, because if it's an elderly patient, we can individualize the protocol, stimulation protocol, and so that we have more number of oocytes to at least achieve one euploid blastocyst for that patient.
Yes,
So
ma'am.
that's the strength of this paper. So I don't think we have any questions. So happy Diwali, and I think happy Dhanteras. And
Happy
thank
Diwali
you,
to
Dr.
everybody.
Punita and Dr. Niharika.
Thank you,
And
ma'am.
thank you,
Thanks a
Deepika.
lot, ma'am. A very happy Diwali to you and a happy Dhanteras.
Happy Diwali.
Okay.
Diwali to everyone.
Bye-bye.
So thank you very much to all the faculty and all our esteemed attendees who were present with us. I'd just like to take 2 minutes of yours. Here, Jackson Pal presents to you Cystelia M. Cystelia M is formulated with ideal 40:1 ratio of myoinositol and dechirioinositol to restore ovulation and reproductive health in women. Also, we have Lycored M tablets. Lycored M tablets of natural lycopene fortified with N-acetylcysteine, enriched with CoQ10 and L-carnitine. And for added advantage to win the race, Lycored M contains 2 proprietary complexes, natural lycopene as lycobeads from Israel and Carnipure sourced from Switzerland, which gives L-carnitine. Apart from this, I'd like to take you through our My Sakhi CSR initiative, that is Jackson Pal Pharma's CSR initiative. Jackson Pal has taken up this initiative as a part of our commitment to improve women's health across all life stages, from adolescence to menopause. Empowering communities has been the motto of My Sakhi, and apart from building sanitation facilities for girls' colleges in Punjab and Uttarakhand, donation of medicines for charitable causes, this website mysakhi.in provides educational content with public awareness programs by leading medical experts to educate and raise awareness about women's health. These recordings are shared for wider access for the public on the same website. Please do visit this website mysakhi.in and explore more. You can scan the QR code on the screen to reach the website. Thank you all so very much for joining us today, and we look forward to the next Journal Club by ISAR Haryana. Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.